Morning. So I'm going to take it up a level in terms of, sort of level of abstraction here to talk about the heady topic of the future of interoperability. The topic was given to me just so you don't think I come in with the hubris of saying, I'm going to tell you the future of interoperability. So I was asked to speak on this. I came to healthcare from management consulting, which, as you know, is, likes to rely on a lot of slides. And so normally I would come here, 30-minute presentation, bring about 50 slides, whip through them, all of you be able to figure it out. And then a few months ago, I showed up at a place where the technology just failed completely, and I found that I had to present without slides, or without slides in that case, and I found that it went much better. So I'm going to use one slide, and I'll use that to help us think about at least my thoughts on the future of interoperability. And so I've got the 5 enablers and the 5 risk areas. Overall, I'm very, very, very sanguine about where interoperability is and where it's headed, and I'll describe that to you in a second, despite the fact that I've got 5 and 5. I think that the 5 enablers are actually stronger than the 5 risk areas, and I've intentionally put them as risk areas rather than barriers because I don't know that they're necessarily barriers, right? All of these things are about risk, but I think that the enablers are sufficiently strong and getting stronger that we all ought to feel pretty good about where this is headed. But let me describe that to you now. So what's the first thing that makes me feel good about interoperability? Well, the first thing is that we have EHRs. Right? I can't tell you how often I talk to hospital leaders, providers, other people who say, well, we've been waiting so long. I mean, interoperability is a miserable failure, right? We've been waiting for so long. You can't have an ATM network if you don't have ATMs, right? And if you looked at the industry, a short 5 years ago, something like 15%, 10% of ambulatory physicians had an EHR, right? And the 10% or 15% who had one, half of those were their brother-in-law's Access database. The other half were Microsoft Word with macros, right? But no kidding, those were electronic health records. And then hospitals were something like 30%. I forget what the numbers are. It's 30%, 40% that had something like an electronic medical record. And I think, as all of you know, most of the leading hospitals at the time actually had custom systems, right? So you look across, and all the leading hospitals now, that's changing, right, as we flip over to commercial vendors now. But at the time, they were custom systems. So when we say that we've been waiting a long time, I mean, we've been waiting 10,000 years for flying cars, and we still don't have them, right? I mean, when does the clock start ticking? If you ask me, the clock started ticking about 3 years ago. 2 to 3 years ago, in an industry that is the most complicated sector of the US economy, bar none, right? And I don't mean that because medical, healthcare is more complicated, inherently more complicated, which it is in lots of ways, but also as you look at it from an economic perspective, the fragmentation of supply and demand make healthcare just a lot more difficult in terms of technology deployment and technology being used to sweep an industry, more difficult than any other industry that you look of. I looked at data that the Department of Commerce has called the Herfindahl Index. For those of you who studied economics, you may recall the Herfindahl Index is a measure of concentration in an industry. And industries that tend to be more concentrated, not surprisingly, are the industries that use technology first and most effectively to kind of sweep the industry. The airline industry, the financial services industry, insurance broadly, those are the industries that took technology and took it to the next level, right? Retail stores with Walmart, Home Depot, all of that. Healthcare, it turns out, ambulatory healthcare was the second lowest in terms of industry concentration. The only industry that was less concentrated than healthcare was florists. Right? Believe it or not. I know that's changing, right? Right now we've got hospital consolidation, but as you know, that goes like this, right? That doesn't go like this. I mean, historically, that's kind of gone like this. And as hospitals realize that they're losing money on all those ambulatory practices, it's going to start, going down again. So, so my point is that we shouldn't think that we've been waiting around for thousands of years for interoperability. I would argue we've just been waiting a couple of years, and not surprisingly, in an industry that is the most difficult sector, it's taking a little while to sort of figure out how that unfolds. Second is we finally have demand. Part of it related to the fact that people have ATMs, right? When you have an ATM, you want a network. When you have a telephone, you want a telephone network. When you have a fax, you want other people to have faxes, and you want to be able to connect with them, right? So that's partly related to the fact that the technology is now in people's hands. The other part of that, though, is the move to value-based purchasing, which, I don't know about you, but I've been amazed at how fast that transition has happened. Faster than, in fact, the value-based purchasing contracts are getting put in place. I mean, it's amazing how many organizations respond to the need for value-based purchasing kinds of activities, even though they themselves don't have an ACO contract, right? They don't have any kind of contract like that, but they realize we better start moving in that direction. Otherwise, someone else is gonna, get there ahead of us, right? And maybe you think of that as a negative market force. I think of that as a positive thing, that people are actually moving and they're trying to think about how they change it, and they're trying to think about how they use technology to do those things. My organization works with a lot of provider organizations on EHR optimization, HIE optimization, and I can't tell you how many organizations who we work with literally flip overnight when they get an ACO kind of contract. Whether it's an MSSP contract from CMS or some kind of commercial contract, they will literally flip, meaning that one day they're just sitting there, they're a network, they've been contracting, here and there, they have, 400 providers, they're on 30 different EHR systems, and the minute they sign the MSSP contract, all of a sudden it's, oh my God, we have to connect up all these EHRs, we need an analytics platform. What happened? You're thinking, wow, I mean, this has been going on for about, 3, 4, 5 years, and you've let this sort of accumulate, but now you have the contract and you're really paying attention to it. My point isn't to criticize them. My point is that that kind of switch to a different payment mechanism completely changes the way the organizations think, and they start really thinking about consolidating their platforms, and they start thinking about interoperability. So I think that's huge, and I think more than any of these other factors, that's really huge. And I would also point out that 5, 6 years ago, there was very little demand for interoperability. We helped thousands of organizations implement electronic health records. 5, 6 years ago, I don't think there was a single provider organization that I can think of that when we were developing the requirements list with them before we started the vendor selection for their EHRs, where they had interoperability in the top 10, right? Certainly not in the top 5. And it's now flipped. It's now flipped. We work with a number of provider organizations now. Interoperability is like 1 or 2, and they want real live demonstrations of interoperability, customer references, show me what standards you're going to use, how you're going to connect to this, how you're going to connect to that, right? That's really different. So just like in any market, the supply side isn't going to respond unless the people who are paying for the systems are asking for it. Not in a hand-wavy way saying asking for it, in a real live way saying, I'm actually not going to pay you unless I have that kind of thing in place, right? So that's really different than where it was just a short while ago. The third thing that I think is really important is the growth of networks. So what do I mean by that? In almost every industry that has some kind of interoperability need, it's the growth of networks that really take it to the next level. So networks solve last mile problems, right? The problem that you have is that in clinical care, for example, you've got hundreds of thousands of settings, and that's just if you think of hospitals and ambulatory physician offices, right? If you start expanding it out to other kinds of clinical settings, LTPAC settings, other types of settings, all of a sudden you've really got, close to, it's hundreds and hundreds of thousands, right? And the problem is, how am I going to connect all those up, right? There's no way in that kind of fragmented system you can imagine that everyone's going to have the same type of technology, everyone's going to use the same type of standards, and we're able to coordinate all of that, and I'll be able to connect all of that sort of in a peer-to-peer way, right? So you have networks that form to solve that last mile problem, to say, I'm going to connect you up, right? AT&T comes in and says, I'm going to create a wireless network, I offer these services to you, you purchase mine versus Verizon. And then the problem is, how do you connect up those networks, right? And it's only in the last year, really, over the last year and a half, that we're starting to see sort of just the emergence of these kinds of networks that may be able to solve some of these problems. So which networks am I talking about? Care Everywhere, the Epic network, right? People think of that, people don't think of that as a network. They think of it as a walled garden, right? I would argue it's in some ways the opposite. It's solving a real live problem of connecting up systems. Now, Commonweal is another organization, right, that is a consortium of a number of other vendors, Cerner, Athena Health, Meditech, eClinicalWorks, and they're now, this year they have a target of 5,000 settings live on the Commonweal network, right? So all of a sudden you start to say, oh, okay, my problem now isn't how do I connect every Allscripts user with every eClinicalWorks user with every Epic user. My problem is how do I get the Commonwealth network and the Epic network to talk to each other in the same way that my problem was how do I get the AT&T network to talk to the Verizon network rather than worrying about all those customers. And each of those networks is going to do whatever it does, right? But there's a bridge there that will define what happens across those networks, and that will be the basis of nationwide interoperability. Right? I mean, you think it's a fairy tale, right? And I'm sure you're like, oh yeah, that's going to work. Well, that's the way it's worked in other industries. In 1901, in the US, there were 2 million phone users, believe it or not. There were 2 million individual phone users in the United States in 1901. And about 2/3 of them were connected with each other by the AT&T network, MAeBell, right? The old AT&T network. And this was at a time just when they had just developed networks. Just before this time, about 10 to 15 years before, so the late 1800s, the phone systems they weren't switching networks, right? There were no switches in the middle. So if you wanted to have, if I wanted to connect to Blackbird and I wanted to connect to Gotham and I wanted to connect to Adrian, I would literally have 3 phones, right? Just like the old Batman, right, with the Commissioner Gordon. I would literally have 3 phones. I'd have my phone to Blackbird, I have my phone to Gotham, I have my phone to Adrian, right? And you think it's comical now, right? The idea of, oh, okay, I have 10 people I want to talk to, I've got 10 phones. Think about how your HL7 interfaces work today in a hospital, right? It's exactly that. It is exactly that, right? But then along came these switching networks, right? So let me go back to the phone analogy here. And AT&T covered 2/3 of those 2 million users in one network. 1/3 of those users were covered by multiple other networks. I would usually ask you to guess how many networks those were. Every single time I ask that, people are way low, like by an order of magnitude. There were 3,000 networks covering the remaining 1/3 of those users. 3,000 networks, right? So one was covering 2/3, 3,000 covering the remaining 2/3. That's where we are today, I would argue, right? It's not just Epic, it's not just Commonwealth. There are a number of other networks. There are statewide HIEs. Most of them are going to die. I'm sorry for those of you who are involved in those. They are. But then we have Direct Trust, which handles a certain number of things. We've got HIST. You got all sorts of other things. PCORI could be an emerging network. You can imagine there are different clinical affiliation kind of networks. All sorts of these kinds of networks that are all going to be, sort of trying to figure out what is the best affinity dimension for them to be able to provide those last mile services to their users. And the question again at the end is going to be, well, how do I connect those networks up? Not how do I make every network be the same, or how do I say that everyone has to be a part of the same network, right? That's really the challenge here, and that's where we are right now is, sort of just at the point where you can see a critical mass and the opportunity to say, well, there's a critical mass. If I could get 3, 4, 5 of those organizations or those networks to figure out a way to cross-connect in a way, I'll have solved the problem for 70% of the country. And then the rest will follow, right? And that's the way it happened with ATMs. That's the way it happened with telephones. That's the way I think that's the way it'll happen with interoperability in healthcare as well. There is an organization, Care Equality, which is it's actually an initiative that's run by the Sequoia Project, which is trying to do this network-to-network kind of thing. It's a challenge. One of the challenges that we have, and this gets to my next point, is that, and Care Equality is a great example, is that we have terrible standards in healthcare, and that's a real problem. So Care Equality is a great example. What they're basing the exchange on, and this isn't a criticism of them, they want to move forward and they've got to do what they have to do because you got the standards that you have, right? And that's what you got. But they're using a set of standards that were developed in the 1980s, 1990s, and they're very complicated and are healthcare specific, right? And that's a real challenge. When I talk to technologists, folks from Kendall Square, Silicon Valley, the one thing they say about healthcare is, where the heck are all the technologists? Right? Where are they? I mean, physicians aren't technologists, so all of you in this room may be, but in general, where are the technologists, right? That's what's really driving the rest of the internet economy. And the reason that there are so few technologists in healthcare is because they look at those implementation guides and the Care Equality one. Again, this isn't to criticize because they're making progress in that, and they have to work with what they have to work with. But look at that, and it is a 57-page initial implementation guide. which links to about 6 or 7 implementation guides, each of which is something like 200 pages long, all of a sudden it's like, wow, I've got an implementation guide that's like 1,500 pages long in a Silicon Valley or Kendall Square, environment where if I can't figure it out in half a day and then tell my developer, develop it in a week, I'm not even gonna touch it, right? I'm not gonna come close to it, right? And that's one of the big challenges we have. That's the opportunity that FHIR enables. And I know Stan's here. I think Chuck is going to be here to talk about FHIR, so I won't talk about that in great detail. But the opportunity of FHIR is not that it's the silver bullet, my personal view, not that it's the silver bullet standard that's going to solve all the problems that all the other standards did, because it's just another standard, right? I mean, they're just computers. It's just a standard. But what it does is it democratizes interoperability in a way, because it opens it up to a whole other group of technologists who will be willing to pick it up and will be willing to start banging away at the system, and they'll start banging away at the system in a way that our current ecosystem doesn't allow, right? And that's huge. I mean, I think that's really huge. There are other things that it allows as a standard. It allows, discrete data kinds of exchange in a way that our current standards are, clunky because they're more document-based. I mean, that's all, that's all fine, and that's a part of the opportunity there and a part of why that's going to be more valuable. But it opens up the opportunity for a broader group of technologists to come in. It opens up the opportunity for patients to start banging away in a better way than they do right now at the system, right? And I think that's huge. So my last enabler is that the threat of government regulatory action has been huge, actually. I didn't think it would be. Someone said this last summer, and I was like, that's not going to happen. No one's going to pay attention to that. I was wrong. People are definitely paying attention to it. And as the legislative drumbeat gets louder and louder and stupider, which isn't surprising, right? But it's in keeping with the presidential race, so it's very consistent. But I don't know, for any of you following that stuff, I mean, I think it's absolutely bananas, like all of it, completely bananas, and we should all oppose all of it, my personal view. But be that as it may, the threat of that kind of looming stupidity is driving people to say, we got to solve this problem, right? We really have to solve this problem in the private sector, or they're going to do it to us, and they're going to do it to us fast, right? And that, that's huge. That's a great motivator. So let me go to the five risk areas. The first is the government will actually do some of that stuff that they're proposing, right? I would say that is a great risk area. I think that will put a great freeze on certain ways of interoperability, that if it gets deployed in certain ways. They have things in there right now that say that they want to legislate that the Office of the National Coordinator will be a convener for nationwide interoperability. I have no idea what that even means. I mean, there are no legislative hooks, right? There are no hooks that says, well, what does that mean to be a a statutorily required convener? The National Coordinator's Office isn't involved, doesn't have any more regulatory authority over interoperability. They don't have any. They're not a participant in the market. If you think about the way other markets work, other network markets work, so let's take financial services, ACH transactions. The Treasury Department and the Federal Reserve play a huge role in NACHA, which is kind of that network of networks organization, right? And on the banking side. They don't do it because they're a regulator. They do it because they're market participants. They do it because they do 10 gazillion transactions a day. And so they exert their influence in that organization as just another market participant, albeit a very important one. ONC doesn't have that. Who does have that? Well, CMS. They participate in market transactions every single day. DOD, VA, INS, right? Those are the services that you can imagine starting to play a real role, exerting their market influence rather than regulatory influence. But the congressional language right now has it completely backwards. So I think there's a whole bunch of stuff in there. They have a rating system that the federal government is going to rate electronic medical records based on 1, 2, 3, 4, 5. Right? I'm kind of crazy. I don't even know what that's all about. So I think that there's a real risk there that it could really goof a whole bunch of things up and could slow things down. It's not going to stop it. I don't think it's going to stop it. I just think it could slow it down, or it could unfold in sort of perverse ways that set us back about 5 years, and then and then we'll get back to where where we're going to be. Second concern, or second risk area, is FHIR hype. So I'm really bullish on FHIR and the progress, but it's a very early, nascent, infant kind of standard, right? And there's incredible hype around it. And people are thinking that it's going to solve all of the problems. The CLASS organization that you may know is kind of like the Consumer Reports of health information technology, did a study just last September, I think, on interoperability, and they asked providers. So CLASS is like Consumer Reports. They ask providers, right? They don't go and ask vendors. They ask providers about their experiences, what they think. And they asked them, what do you think are going to be the most important things that are going to move interoperability forward? And there were like 15 things listed. Fire was the most important thing. And my first reaction to looking at that was, I'll bet 90% of them couldn't even explain what it is. Which isn't to say, they're not stupid. They're physicians. They don't pay attention. They're not focusing all their time on the latest and greatest RESTful API OAuth-enabled standard. But the point is that there's a lot of hype around it, and I'm concerned that, A, that's going to set unrealistic expectations, but B, a harder thing or a more insidious thing could be that people want to get out ahead of it before it's ready. And then we'll be in a world where we're like HL7 version 2 kind of world where you have a standard, but it's got 10,000 flavors, and all of them somewhat, but not really, compatible unless you do a lot of engineering work. So there's that risk today. There are, initiatives out, the Sync for Science initiative, DoD, VA, market pressure, all of them saying this is all going to be fire enabled, this is all going to be fire enabled, this is all going to be fire enabled, and it runs the real risk of saying there's going to be this flavor of fire, and this flavor of fire, and this flavor of fire, and this flavor of fire. Right? So I think that's a risk area that'll just slow things down. Again, it's not going to stop it. If you use stage 3, I think it's a real risk area because I think it's a real problem. Most providers are jumping ship and are really rebelling against it, right? And you have this weird phenomenon of an incentive system where you're being asked to do more, but incrementally you're getting paid a lot less because of the way the meaningful use payments ran, right? And the meaningful use stage 3 has a lot of sort of insidious complexity in it that I think is slowing people down. It's forcing vendors to do a ton of things that most providers don't want them to do. And a whole bunch of the certifications related to meaningful use stage 3, now they're not necessarily tied, the certification is separate, but it's a certification that the vendors have to meet that isn't tied to a meaningful use requirement. So they're saying, here vendor, you have to do these things. Oh, there's no requirement that a provider use any of those things, but boy, you better deploy your system with those things there. We have no idea whether providers want those things or not, right? But every resource that you take on those things is a resource that's not being used on accelerating fire, accelerating, sort of the maturity of these kinds of networks so that we can have, more practical interoperability that physicians and patients really want. Commercial payer sluggishness, sorry about them. I think one of the reasons I put this out is that, I don't know about you, but I have been, really surprised at how fast CMS has moved into accountable care and how slow the commercial payers have been. So when Obamacare first passed, you may know that one of the things that it did, that it doesn't get a whole lot of attention in sort of the public press, but one of the things that it did is it allowed CMS to do demonstrations without having to go back to the Congress and prove the results of those demonstrations before they can implement them as programs, right? That was huge. And it was a small kind of thing that, so the people who were in the guts of this understood the significance of it, but, overall it's like, oh, okay. That's been huge. I mean, my thought at the time was, oh, okay, so what this is doing is it's allowing the government insurers to keep pace with the innovation that's happening on the commercial side. And what we've seen, at least from my perspective, is the opposite. The government insurers are actually the most innovative around this stuff, and they are sweeping across the country with these kinds of programs that are pushing the envelope, that are pushing the healthcare delivery system in ways that I never imagined would happen in such a short period of time. And the commercial payers are barely keeping up. They're barely keeping up. They're not showing nearly the innovation that I think that Medicare and Medicaid are. And then we also don't have commercial payer interoperability, right? In my company, we have switched health insurance in like 3 or 4 times. Why do I have to get a new card every single time I switch my health insurer, right? And everything is so complicated, and so I'm always struck by commercial payers pointing their fingers at the physicians when they themselves have the least interoperability around some of the most convenience kinds of things that patients want, which is a challenge because as we move more and more from interoperability, people start to mush together clinical and administrative, right? They don't see those as necessarily different, right? If I can't do prior auth, that's an interoperability issue. Yeah, it's administrative, it's not clinical, but it's an issue. My last risk area is state governments. Oh my God. State governments are a real problem in interoperability. They're a problem for any nationwide industry, right? Car manufacturers have the same issue. I mean, plastic bags are banned here, they're not banned there. You have all these things. GMO labeling is allowed here, it's not allowed there. It's a little bit deeper in healthcare because it affects fundamental operations. Privacy is one aspect of that. Different privacy laws. Now, computer systems are good at managing this kind of thing. The problem is that a lot of those privacy laws are just hard to interpret, right? I can't tell the computer to figure out something that I myself can't figure out. And that's the situation we're in with a lot of these privacy statutes as they start to come together and you realize that they're not reconcilable on the face of it. And for any of you who have tried to do this across states and you think about all the different laws that start to pertain to the way, whether it's emancipated minors and sensitive conditions and this and that, all of a sudden and some of it's, per event, consent, others, is written consent based on this form that I developed in my state. It's really very difficult to figure out how you scale that. It will be scaled. Again, computers are really good at doing that stuff, but it's just slowing things down and it's a risk area. The last issue with state governments that I've found is that there are too many initiatives going on that are slowing the market down because people can't figure out how to respond to them. So just in Massachusetts and New York, for example, you have the DISRIP program, that many of you may be familiar with, which is Medicaid waiver, which is giving grants all over the state. And in New York, it's like $1 billion or something, and it's a huge program. And what it does is everyone stops in their tracks because they want to get these grants and they don't invest in the things that they think are going to make sense right there in front of them according to their own business needs because they're waiting to see whether they get that $200,000 grant from the state government. And those grant cycles are like a year. Right? There's like a year and a half. And then you get, in Massachusetts, we have the CHART grants that come from the state government. And you have DISRIP grants, and you have the MAeHC grants. Literally, I'm not kidding. You have all these different grants. So all these provider organizations sitting around and waiting for these grants, trying to figure out how to reconcile all of them so no one will accuse them of double dipping. In the meantime, over a year and a half or 2 years, they haven't made the investments in interoperability or other kinds of things that are going to serve their patients better because they think that they're going to be able to get that money. That's a real problem. It's a real challenge, and it slows things down. But anyway, I think I've gone over my time. I really appreciate your attention and look forward to any questions you might have. Thank you.